Welcome back, everyone. I hope you had a chance to get a cuppa, maybe even a biscuit, if you were lucky. We're going to start again now, and I'm really pleased that we're going to introduce Professor Nav Kapur from NCISH. So Nav has written what I think is quite an astonishing amount of academic papers. He's won some pretty prestigious awards, but actually he's used all of those years of research and the wealth of knowledge that he's got to lead, again, some really practical things which are creating change. So leading the development of NICE guidance around self-harm, leading some national work, supporting local areas to develop and improve their suicide prevention activity. So really brilliant to be able to hear the latest about the research the centre's been doing. Over to you now.
Thanks so much, Jackie. Hello from Manchester. I'm delighted to be joining you. It's been a fantastic morning. Thanks, of course, to the three dads. That was absolutely brilliant. Thanks to Jackie for steering us through. Now, before the break, you heard from Lewis about our annual report, and that's obviously one of our main outputs of the year. But we're also a research unit, and we're a research unit that really kind of prides itself on producing research that's going to have an impact, a real world impact on patients and their families. So it's my particular pleasure today to tell you about some of the research we've collectively been doing over the last 12 months or so. So let me just share my screen. Jackie, I'm hoping that is visible for you. Oh, perfect. Okay. So these are findings not just from NCISH, not just from the National Confidential Inquiry into Suicide and Mental Health Safety, but from our wider research unit. And I'm going to focus on three areas, many of which have come up in the chat and the Q&A, so I'm hoping I can answer some of the questions as we go along. The three groups are young people, studies which then have explored the link between ethnicity and suicidal behaviour, and then important work thinking about how we best help people, how we best assess people after they've hurt themselves. So let's take each of those in turn. Young people. Now, you've heard from Lewis about suicide in young people, but one of the other things that's really important is self-harm. So when young people injure themselves, poison themselves, hurt themselves in other ways. And this is a study from one of our PhD students working on our wider patient safety centre, Łukasz Cybulski. And what it shows, on your screen here are rates of self-harm in girls, and what it shows is an increase in self-harm over time. Again, these are pre-pandemic figures, and a particular increase in girls aged 13 to 16. Now, we're seeing that self-harm rise also in boys. People are always asking, well, what's the rise in self-harm down to? We don't know for certain, but there's the mental health pressures all our young people are under, pressures related to education. Social media always kind of comes up when we're discussing self-harm rates, but it has positive effects on mental health as well as negative effects. And there's also something probably around our kind of societal attitudes to self-harm, how to the extent to which it's disclosed, the extent to which it's kind of out there. So increasing rates of self-harm. Here's another one of Łukasz's studies. And this looks at self-harm and suicide, and like the previous study, it's through a kind of primary care lens. So it's really focused on what's happening in primary care, in general practice. So it's not just mental health services, which our annual report focuses on. And one of the important messages is, there is an opportunity for health services to intervene here, because most young people who had self-harm or, sadly died by suicide had been seen in primary care, had seen their GP in the previous year. So an opportunity to intervene there. The second bullet point is a reminder that self-harm is an important problem in its own right, but also it's associated with suicide risk. So around 2/3 of young people who died in Łukasz's study had a history of previous self-harm. And only about a third had a recorded psychiatric diagnosis, and probably that's a result of people not coming forward, psychiatric diagnoses not being recognised. So it's not just that mental illness isn't an important factor in suicide in young people. It is for many young people, but there's something there about access and recognition. That's self-harm in primary care. The other place where people present often after they've hurt themselves is the emergency department. And here's some data from the multi-centre study of self-harm. So we run the Manchester Self-Harm Project here in the department, but we also collaborate with colleagues in Oxford and Derby. And this is a study led by a colleague in Oxford. And it looks at self-harm in younger kids. So that's been a bit of a concern over the past few years. So this looks at self-harm in kids aged 12 years or younger. And I mean, self-harm in that age group is less common. It's less common than it is in adolescent age groups. But it's still an important group, and we still need to understand more about them. And what I particularly wanted to highlight from this study is the link between self-harm and deprivation. Again, it's come up a couple of times in the chat. And when you look at the young kids and the areas in which they lived, what you see is the kids who are living in the most deprived socioeconomic circumstances had the highest incidence, if you like, the highest rates of self-harm. Now you see this gradient, across kind of mental illness. You see it in adults as well, but it's really steep here. So, the link with deprivation in young kids who self-harm is even stronger, and I'm sure that's a link we'll want to pick up during the chat. So it's not just all about kind of clinical services. Obviously, it's about socioeconomic circumstances as well. The next lot of studies I want to cover are studies where we've looked at the link between ethnicity and suicide. And the astonishing thing is that prior to last year, we had no good national data on suicide and ethnicity in this country. And that's because ethnicity is not routinely recorded on coroner's inquests, and so not routinely coded by the Office for National Statistics. But they did a very clever thing where they linked census data to death data, and were able to estimate suicide risk by ethnicity. So one important message is for the majority of ethnic groups, suicide rates were actually lower than in the white population. The exception was people who were from mixed or multiple ethnic groups who had slightly higher rates than people from white backgrounds. Why is that? It's possibly due to, again, deprivation. It could be due to kind of alienation or isolation or other factors, or it could be because this particular group don't have some of the protective factors that some of the other groups have. But, an important finding and data there for the first time nationally. But what about the patient population? So this is data from National Confidential Inquiry study led by Isabel Hunt, who's lurking in the chat there somewhere. Hi, Isabel. So this is looking at patient suicide now by ethnic group. And overall, probably rates were lower than in the white population. But the important message here is, we can't really treat people from ethnic minorities as a single group when we're talking about research. That's been the pattern in research, older research going back. Rates did vary between different ethnic groups. And even, we had to do this because of data availability, but even kind of collapsing people into these broad ethnic groups isn't satisfactory. The South Asian group includes people from Pakistani, Indian, Bangladeshi origin. So, our research into suicide and ethnicity has been far from perfect, and, we need to get better going forward. But rates vary. And characteristics vary as well. So people from Black African or Black Caribbean backgrounds were more likely to have a diagnosis of schizophrenia. People from South Asian backgrounds who died by suicide, patients who died by suicide, were more likely to have a diagnosis of depression. So there's that variation. But there were also some common factors as well. So in general, people from ethnic minority groups who died by suicide had markers of kind of increased social adversity, so unemployment, social isolation where people lived. They were less likely to have access to CRHT, stands for Crisis Resolution Home Treatment Team, so an alternative, community alternative to inpatient admissions. They were more likely to be detained under the Mental Health Act compared with white patients from a white background. And they were less likely to be taking medication as prescribed. And one of the really interesting things is, despite all of this, patients from an ethnic minority group who died by suicide had a, if you like, a lower rating of risk. So they were more likely to be rated as at low risk than white patients. So the risk, in some senses, being underestimated. That's suicide. Moving on to self-harm, and this is a study from my colleague Bishop Farouk based on the multi-centre data, so emergency department data on self-harm, young people from ethnic minority groups compared to young people from a white background. One of the interesting things here is, remember that kind of increase in the rate of self-harm I showed you in the white population. There was some suggestion in this study that the increase in young people from ethnic minority groups might have been even faster, although the rates overall are still lower than in the white population, but rates perhaps increasing more quickly in people from ethnic minority groups. But the big message here from this study of self-harm is access to treatment. So everyone's supposed to get an assessment after self-harm, but we found young people from an ethnic minority group compared with white young people were less likely to get an assessment, were less likely to get access to mental health care, and were more likely to be discharged with no follow-up. So an important message there around ethnicity and access to services. The last lot of studies I just want to quickly touch upon is to do with self-harm. So we've been talking about the importance of a proper assessment after someone presents for self-harm for many years. So if someone presents with self-harm to clinical services, they need a proper assessment. Unfortunately, that doesn't always happen, and we can discuss the reasons for that perhaps in the discussion. One of the really kind of quite interesting things that's been published recently, this is a study led by colleagues at the London School of Economics. And what they did for us is they modelled the economic impact of getting a psychosocial assessment, getting a proper assessment after self-harm, and estimated whether that is kind of cost effective, so whether that would save the NHS money. And the way they do this, there's lots of pretty graphs in the paper. I encourage you to look it up, and we've included links to all the papers in the slides. But what they do is they simulate, they do computer simulations, and basically what this graph is showing you, the majority of simulations when they kind of ran models, statistical models, showed that psychosocial assessment, so assessing people after self-harm, was cost effective. So actually saved money because of the impact on well-being, on the impact of repetition. So, doing psychosocial assessments will save the NHS money in the long run. Despite that, many people still don't get a proper assessment. Somewhere between 40% to a half of people after they present to hospital don't get an assessment. And this is a study, a qualitative study led by my colleague Leah Quinn-Liven, who works in the Patient Safety Centre, looking at why people weren't getting assessed. So this is patients and carers, a qualitative survey, and there are patient factors, service user factors for why people might not get an assessment. So long waiting times, being very distressed, not being assessed in a suitable environment, perhaps having previous negative interactions with staff, or thinking that assessments are pointless, or really having a firm attention that they didn't want help, and they either wanted to end their lives or definitely kind of self-harm. So there are these reasons, patient reasons for non-assessment, but also I think some of these organisational circumstances, organisational reasons are really interesting. So gateway issues, people not being offered one, staffing issues, exclusion, so people either not being offered a assessment because they've got alcohol on board, or capacity, people either saying, well, you do have a capacity to refuse an assessment, or you've not got sufficient capacity, cognitive capacity to agree to one, so capacity being used as a kind of excuse for non-assessment. But also risk, and I'm sure we'll talk about risk. you know, this idea that you're either at too high a risk or too low a risk to kind of get an assessment, some methods of self-harm more likely to lead to assessments or others. And this one, I think that's particularly kind of troubling, where if people were presenting frequently with self-harm, sometimes they were less likely to get an assessment, despite the national guidance that ourselves and others have put out to say everyone needs a proper assessment after self-harm. So that's reasons for non-assessment. What about when people do get assessed? What helps is another study from Lear and colleagues. This isn't surprising, but here are some of the things that patients and carers found helpful. You know, care that was kind of humanizing, a collaborative discussion, having space and time to talk, so assessments that weren't rushed. You know, the professional kind of conveying compassion and reassurance, and also receiving help. So it's something there about the assessment itself, the interaction between maybe the clinician and the service user, that kind of connection, that empathy, but then also something about follow-up care and plugging people into the care they need. So I've told you a little bit about studies into young people, particularly self-harm, talked a little bit about ethnicity and suicidal behaviour, and assessment after self-harm. And here's a quick potted summary. So we've got increasing rates of self-harm in young people, but I think scope for healthcare intervention, you know, it is a societal problem, but it's also a healthcare problem, particularly I think in primary care. So we're thinking a lot about primary care and what we can do. There of course are the links with socioeconomic adversity, which are particularly pertinent at the moment. For ethnicity, we've got lower rates of patient suicides in many ethnic minority groups, but important differences between groups. So the characteristics aren't the same, the rates aren't the same. And one of the things I think we have to really grapple with is, you know, why do some people from ethnic minority groups have poorer access to services, and what can we do about it? Psychosocial assessment after self-harm, it's vital. It also is cost effective, will save the NHS money, but it sometimes doesn't happen, both for those individual reasons and for those structural organisational reasons, but it has a number of helpful elements, and I think importantly we can do it better going forward. As with Lewis, what I'd like to do is just finish with a slide of most of our staff. Some have been a bit elusive, so we've not got absolutely everyone on here, but they're the people that produce this research. So thanks for listening.